Hello, everybody. Again, sorry, you'll be sick of the sight of me by the end of today. So, moving along this morning, we're going to be now talking about simplifying self-care for venous leg ulcer management. So we know there is an escalating burden of wounds, and you might have heard us talking about this a lot over the past, kind of 5 years, really. There was a study done by Julian Guest, and it was originally done on data from 2012-13, and the cost to the NHS was £5.3 billion. Well, he redid the data again, and on the 2017 and 18 data, it had gone up, and the cost then stood at £8.3 billion cost. That's phenomenal, isn't it? Now, when they redo the study and they take into account the period through COVID and everything else, my goodness, I don't even want to think about what it's going to be like then. I did a small audit in my own trust, and I knew that we had a problem with patients not getting the correct assessment, management, and self-care support, the accurate self-care support for their venous leg ulcers through that period. So, we have to work with that data, and we've got some figures. 1 million patient, which equates to 2% of the UK adult population affected with a leg ulcer. That could be, different types of leg ulcers, but it's a lot. £3.1 billion annual estimated healthcare cost just for the leg ulcers. And then we have 50%, those of us who work in the community, 50% of the time they recorded was spent on leg ulcer care, on wound care. And that won't surprise you, those of you who work in like district nursing, places like that. And sometimes I'd argue it's probably more than that, isn't it? You kind of have, I know we do, as district nurses, it's like jack of all trades, isn't it? I was a DN for years before I went into tissue viability. You kind of do lots of things, but palliative care and wound care are probably up there on the scale of things that you do most. And the biggest cost in all that money there, that 3.1 billion or the 8.3 overall wound care, is your time, is nursing time, your visit, going out to do, mopping up wet legs, patients coming into clinic, your time given to that. That is the biggest thing, not the products, it's your time. 71% there was a 71% increase of wounds from that first study to the one that was done on the 2017-18 data. 71%. I mean, what's it going to be, on the next one? Up to 69% of leg ulcers recur once they've healed in community. These are facts. We've got the data to back them up. And why is this? Because if a patient, what happens is, we know what happens, don't we? We put our compression systems on, the leg ulcer heals, and then we say, look, we want you to go in to wear this maintenance hosiery, and people often go, oh no, I don't want to wear that now. They want to just go on and be free. So there are ways and means, and there's big research studies being done on how we can improve and the adherence to using compression, lifelong compression sometimes, but also to reduce that recurrence rate. So there we have that burden of illness league table, and that red line right in the middle is the wounds when it was done on the last study. So we can see that £8.3 billion. Above that, we've got top of the shop, we've got diabetes, won't be a surprise, mental health, cancer, heart disease, arthritis. Then we've got the wounds, and under that we've got obesity. Now, obesity is talked about a lot. We see it in the media. It's talked about with, we get things from the government coming out, the Department of Health, on ways to tackle. We need to tackle this. And yes, arguably, all these things kind of affect each other. People are at more risk because they've got these other factors of then getting a wound and a wound becoming hard to heal. But, we don't often see, do we, people on TV. We don't see them on the This Morning sofa with Phil and Holly talking about their leg ulcer or their pressure ulcers, do we? So, we need to try and elevate this because it obviously is a massive problem. So this is the breakdown of wounds types in the burden of wound table from the study that was done. And the reason we've put that on is because you see that great big red line, the highest line up there on the end, that is venous leg ulcers. So it's higher than pressure ulcers, which, you know, politically we've always focused a lot of attention to. They've got diabetic foot ulcers, you know, and all of these are obviously very important in their own right. But we know that the prevalence of venous leg ulcer and the spend on that is through the roof. But if we assess and then manage it properly, that'll lower down because compression and all the, you know, the things that go with the good management is a science. We know that it works. So we need to start thinking differently in order to improve the healing rates and also to reduce that burden on the NHS and to bring that spend right down. So, you know, how do we do that? What are the ways in which we can do it? We have guidance now. We've got the lower limb recommendations for clinical care. Now, the National Wound Care Strategy Programme applies to England, so I apologise for that. But you have great work that is going on. Your TVNs are really active. You know, there's all sorts of work that is going on. You have great practice here. and things I know in Scotland and here in Wales and in Ireland, you know, things are trying to be kind of replicated. But yeah, so there is, but you can Google this guidance and use it as a reference if you just want to, you know, because we should always, like from days like today, go on and then take our learning, you know, self-directed learning and do further reading. There's best practice statements out there, and then we do have this. So this guidance applies for people who have wounds, one or more wounds below the knee. So venous disease, I think most of us know what venous disease is, but for those who don't, just as a little recap, so it's you know, it's a condition of the venous system. So it occurs in the legs, and it's about incompetent valves. So running through, you know, our bodies, we know we've got the arterial system, we've got our venous system, we've got our lymphatic systems. We're like road maps, you know, all running through and all kind of working together in combination. So in our veins, and we've got big veins and we've got smaller superficial veins, what the job is for the blood to get pumped right up from our toes, up to our, you know, to get the oxygen in the lungs and then through the heart and then through the arterial system. So it's on that continuous loop. Now, to get something from down there up here requires work, and that's why we've got pumps in our calf and in our feet. So when we can tap our feet, or we're moving or dancing or whatever we're doing, just even standing up, putting the profile up on somebody's bed if they're not mobile, this all activates the venous system. So the blood will pump up through the body, and in there we have these little valves. The body is an amazing thing, isn't it? We have these valves which then close shut, so it stops the blood dropping back down. But unfortunately, some people have a risk of those valves getting damaged, and as we get older, everything goes south, doesn't it? So, you know, they start to droop and drop a bit as well with age, but with lots of other things. So then we get venous hypertension, so the blood, some goes up, but some drops back down. And then we start to see problems, don't we? We can see on our patients' legs, we'll see brown staining or red staining. And, you know, that's just the iron products in the blood that are seeping out into the tissues. That's one of our signs somebody's got venous disease. We might see little blue and purple veins sort of protruding around the ankle flare. We might get types of eczema, varicose eczema, might get swelling in the legs, so leg edema, and also varicose veins. And some of us might suffer with that as well. So we also can have venous obstruction in venous disease. So that's commonly due to the venous thrombosis. So it might be an injury to the vein, or that muscle pump is inactive because of mobility, paralysis, things like that. So it's important for those people that they have got some element of exercises, might involve our physios, OTs, to be able to support them with that for their venous function. So a lower limb ulcer. So a lower limb ulcer is a wound that is, and when we talk about a leg ulcer, it's above the ankle but below the knee. If it's below the ankle, then it's classed as a foot ulcer. Our venous leg ulcers predominantly will occur in that midway between our ankle and our knee. And we call them an ulcer because they are slow to heal. They've become hard to heal for lots of different reasons. And, you know, there's a variation of outcomes. I mean, you know, you can't say for one person, your wound's going to heal in this amount of time, but we have expectations. If we get assessment early and if we get management, the right management and early enough, the right compression, we could have a leg ulcer healed in, you know, maximum of 12 weeks. But some people are living with their ulcers, you know, for years and years and years, which is obviously extending their healing time and their care costs. Now we know, you know, some of our patients, and you know, they might not like the term leg ulcer. And they'll say, oh, it's not a leg ulcer, is it, nurse? Because they've got, you know, fear and history within their families of, you know, amputations, or, you know, we didn't have these great treatments and things that we do today. So we have to use correct terminology, but we have to explain to our patients as well, this is why this is occurring, and this is how we're going to manage it. Remember when it was always 6 weeks, wasn't it? You know, you're filling your wound assessment in, writing it in 4 weeks, 6 weeks. Oh, it's a leg ulcer now, you know. We just don't do that anymore. We say if a wound's not healing, a lower limb wound, within 2 weeks' time, then, you know, we know it's going to be, this is hard to heal now because it's not showing normal signs of the body's healing response. So we need to do full holistic assessment, so we have to do that before treating any leg wound. So it's got to have that general assessment, so all that past medical history, medications, is there any indications or contraindications for treatments that we're going to put into place? Is there any psychosocial factors, environmental factors? Because, you know, what we talk about, don't we, that concordance or adherence, my patient's non-concordant. But we have to explore, why is that? There might be, you know, a valid reason and something we can overcome. There might not be. People are people, aren't they? And sometimes people make their own choices, and we might perceive that to be the wrong choice or a bad choice. But, you know, we should explore the avenues of why is there that barrier there. We do the leg assessment, so we're looking at the leg for all those skin changes, any, you know, different signs and symptoms of how the leg is looking. And we should do that. I know we're talking about ulcers below the knee, but when we're assessing the leg, we need to come up, you know, up. Have we got edema above the knee? Is it into the groin? Is it into the abdomen? You know, we need to look for all that. And then we're doing the vascular assessment. So we know what we mean, don't we? Vascular assessment. So we determine a vascular status. So that's when then we're going to do our Doppler assessment. Is everybody competent in Dopplers? Some of you? Yeah. And we've got handheld Dopplers. We've got automated Dopplers now. You know, we've got a little bit more of a choice, which is great. So we do that to determine the ankle brachial pressure index or the toe brachial pressure index if you're doing a toe pressure, and then that will give us that scoring, and we can say, well, that's yeah, definitely venous disease, or there's some mixed etiology going on there, or ooh, it's below 0.5 and we need to be referring, you know, into our vascular services because somebody's got signs and symptoms of arterial disease and their Dopplers, you know, it's low. Now, what we do have as well, and yes, this is a recommendation in the National Wound Care Strategy Programme, but this crosses, you know, outside of that one document. And we have what's called immediate and necessary care. And so what that means is that we've done that assessment, we've done that holistic assessment, we've got all the information, we've looked at the leg. But, oh, I haven't got my Doppler here today, or, you know, we've only got so many in the team, so I need to plan that in for my next visit, you know, if I haven't got it here today. But what can I do now before I can, you know, refer somebody for that doing, or, you know, however it is the means that you get that Doppler done. So what we can do is, in the absence of red flags, and we'll look at what the red flags are in a moment, we can, and so that's, and lack of arterial insufficiency. So, you know, got the signs of venous disease, the ulcer is, you know, it's not below the ankle, not on the foot. You know, we've got no necrosis going on. We haven't got a pale leg with, you know, like a mottled purpley foot, very cold, you know, signs and symptoms of arterial disease. In the absence of that, we can use mild compression until we get our Doppler done. Isn't that amazing? Yeah. And don't be fearful of this. You know, we can do this. And when I say mild compression, I'm talking of up to 20 milligrams of mercury. And we'll look at, you know, what that does look like. So a wound's failing to heal within 2 weeks. We've done all those things. Yes, we want to do our ABPI, and we want to do it within a 2-week range, really, as soon as we can. But up to that point, we can use mild compression. And if we catch those ulcers at the early stages, they might have healed by the time, you know, they're going on into their clinics and, you know, wherever they need to go for their full assessment. So what are red flags? So we've got red flags listed as an acute infection of the leg or foot. Now, it is a myth that you can't apply compression if somebody has, you know, a wound infection or cellulitis, but they might not let you near them because it might be extremely painful. So it's, you know, toleration level. So just err on the side of caution there. Any symptoms of sepsis, acute or chronic limb-threatening ischemia, and we've got nice guidance to support what that is. And then we've got suspected DVT, you wouldn't apply it then. And if we've got suspected skin cancer, because we need to be referring on then, say, to dermatology to get that looked at and assessed. So what we do need, so if we've got no red flags, we're going to move on to immediate care. We need to do our wound bed and our peri-wound bed preparation. So we need to wash and cleanse, you know, clean it like you mean it, into the wound, disrupting the biofilm, you know, good leg care, washing, emollients. And then we need to be applying just a simple, non-adherent dressing, but if we need some absorbency with it, we'll do that. And then we put in that mild, graduated compression into place. If somebody's got a wound on their foot, then you need to be referring them into your diabetic services if they're a diabetic. Even if they're a wound in the foot and they're not a diabetic, they should be referred into, you know, the podiatry or your foot care services, whatever, you know, you have in your service area of work, because, you know, that might be a critical thing. You know, it could lead to infections, amputations, things like that. So refer on into that service. So why do we need compression therapy for the treatment of venous leg ulcers? Well, it's science. We know that it works, and it works very, very well. So compression therapy is where we apply graduated pressure up the leg on the skin. So we've got the most amount of pressure up the ankle, and then it graduates then up to the calf to below the knee. We may have compression that goes above the knee as well. I mean, we can get sometimes compression tights, can't we? So, but it's graduated up with the highest point at the ankle. So what it's doing is, it's addressing the underlying structures of the lower limb. So that venous hypertension we talked about, you know, the wobbly valves, the incompetent valves inside, it's, you know, it's giving us the gravity with the compression to push the blood up despite, you know, the valve incompetency. So we're getting that good supply of blood that we need, and if we've got a wound there, then that will aid the healing of that. So the level of pressure delivered can be influenced by the amount of compression that we have, and we're talking, we're talking about bowel compression with immediate care, but when we know somebody has a venous leg ulcer and their vascular status is okay, we want to be looking at strong compression. It's sometimes hard to go from here up to here. And when I did a survey with district nurses in the area I worked, and I said, why aren't you applying full compression? They said, well, we don't think the patient will like it. We don't think. But this is therapy. It's a prescribed treatment. We wouldn't reduce somebody's blood pressure medication or take it away, would we? Because think, well, they might not tolerate. We need to be given the best prescribed therapy that we can. The type of material that we use, and we'll look at the different types of options that we have, because that can have an influence on how the compression is used. Have they got edema or not? So it can help reduce and it'll relieve the condition of the lower limb because it's acting on the lymphatic system as well as the venous system as well. So it helps that removal of the fluid. So if somebody's got, edema, and when I always talk about lymphedema, and people sometimes say, oh, that specialist is lymphedema, I don't do that. It's edema. It's just stages of edema. So don't think of it as different things. So here we have some different compression systems. So I'm sure you can all see on this picture there, the first one, we have a bandage systems. So what we do, we advocate the use of compression bandages for when we have very edematous limbs. We have limbs which, when they're a bit unshapen, so you might have overhang of fluid. You have, like on the dorsum of the foot, you've got that, pouch of fluid hanging around the ankles, might be around the knees, just a misshapen leg. And also we've got, quite a bit of exudate from the ulcer as well. So we want to make the leg into a better shape. We want to address that edema. So we've got short stretch bandaging. Okay, because different types of bandaging. There's long stretch where you can stretch it like that, and then there's short stretch where you like that and you can't stretch it. And what that does, it provides a static stiffness index, so up the leg, and that edema can't rebound. It's like, the bandage is rigid there, so it's stopping it from swelling out. If you put a long stretch bandage, you remember the days of 4-layer, do your little figure of 8 and all that stuff. But it stretches, so and it also gives constant working pressures. So people, when they go to bed at night or they're sat in the chair, they're like, oh God, it's kind of the compression's still going. With this, it gives high working pressures when somebody's active or moving about. Even if they're not, just move the feet, activate that calf pump, and the working pressures will go. Sat resting in bed at night, and then the pressures lower. So short stretch bandage is amazing for that. We also have leg ulcer hosiery kits. Now, what a revelation these are. And we've got the Venous 4 trial, which had extensive research, amount of patients within that trial. And what that told us is that if we use a hosiery kit, we've got 2 layers on the kit, nice silky first layer, and then we've got a more compression layer on top. So 2 elements to it, and we can't go wrong because we're all going to apply 40 milligrams of mercury with that hosiery kit when we put it on. If we all apply a 4-layer bandage and we measure it, might all have it different, because that's just human error sometimes in the application. We also have the wraps. They're great, aren't they? So glad that they were introduced. So we've got the ready wrap up there. So we've got a foot piece, we've got the middle piece, there's knee pieces, thigh pieces. We can build up through the leg, and people like these, not as bulky as big bandages. So if we can, we've got so many different options for us to use there, different alternatives. Now, I always believe that using treatment pathways, whatever you call them, pathways or roadmaps in practice, is really good. And so, and they're evidence-based. So what we have here, we've got the leg ulcer treatment pathway, and it was this one has been adapted from Joy Tickle and Leanne Atkin, their pathway they did in 2016. So now it's been updated, and it's the best practice for immediate care for venous leg ulcer management and prevention of recurrence. So it's great with evidence because we can add things in, as time moves on. So based on that strength of evidence, this pathway now recommends that we use self-care solutions or supported self-care or shared care, all these terminologies as a first line approach. Now, I know through like lockdown periods, there were some elements of this going on. Sometimes it wasn't done so well, and that's why we have pathways like this. So we follow it, and we have standardization, and we're doing the best thing in practice. So it's a solution for the whole patient journey. So we've got that patient in the middle there. So we've got evidence base for it, and also we're going to have the prevention of recurrence. So follow the system through and the patient, and we'll look at who we can self-care and who we can't self-care, because I wouldn't say that we can put everybody on our caseloads into this situation, but there's all those people who I did my audit on, who were going to ringing the GP practice during the COVID worst period, would have benefited from this, because they were just being given dressings, antibiotics from their primary care service, whereas they could have had, they've got an insect bite or a knock to the leg. So it always starts as just something in everyday life, a leg ulcer. If they'd have had this immediate care, they wouldn't have then been coming in 9 months to the clinic with, recurring infection, massive, great big leg ulcers. So what compression system is suitable for your patients? What's the best thing to do? So we've got the best practice pathway we've seen, and so we want to know that we've got the wound exudate controlled and that minimum limb distortion. So some patients will still require the bandaging, but then we can then go from bandaging into, say, a hosiery kit or into the wraps, following we've got the leg shape under control. So we've got some images there, so we can see, obviously we've got the red crosses on there, so we're saying these are not suitable for self-care at the moment, so we need to, that's quite a big ulcer. We know venous leg ulcers are historically quite wet, so we need to get exudate under control. We need to reshape that leg, don't we? So we can do that, but then we can then move into it once we've got these things addressed. So that's when we're looking at the bandaging systems, as we said, high exudate, and to do, to get that leg into a good position where we can put our hosiery kit on. So what's self-care? We talk about it a lot. I've talked about it a lot in the past few years, and you hear the terminology, but it's about empowering people, empowering our patients. I know the NHS long-term plan advocates this, about people taking autonomy of their health conditions. And why not with wound care? We've always, I think we're guilty as nurses of going, don't touch that dressing. If there's any strike through, ring up and we'll sort it out, or ring the clinic. We have to let go a little bit. We have to know that some people are able, to work with us in the team with self-care. So if we give them that confidence, the information, the support, promotes their independence. So potential benefits for our services, our health services, that it's as effective as multi-component bandages if we can use the self-care kits. We've done our assessment, it's suitable. We're getting those consistent therapeutic compression levels. It's a low-level skill to apply, and I don't mean that in any detrimental way, but to apply the compression bandage, you have to go through lots of training and OSCEs and competence and things like that. We're talking about people being able to apply this themselves, carers, family members, because we know they're not going to overcompress because it's already built in to the hosiery kit. So that reduces our training issues, and we know, you know, a lot of our in-house training has been suspended, and some of it's kick-starting back again now, but it's been a problem. Saves time, saves money, improves concordance, there we've got that word again, and reduces the recurrence, because people are used to having hosiery on. They're more likely then to go, well, yes, we can go into maintenance hosiery now, and then they'll stick with that. So the important benefits to the patient are greater involvement in the treatment. They've got the improved understanding of the disease. They're empowered. I can help myself. I can be involved in this. Not going, well, there you go, nurse, there's my leg. You deal with it. It's part of them. Improved outlook and outcomes. There's less time waiting for appointments, and greater mobility, because if you've got that hosiery kit on, they feel really comfortable. If you haven't ever tried one, put one on. It's better than the bulky bandages. Can get better shoes on, and it reduces the dependence. And if you're thinking, no, it don't work this. There is a study that was done by a TVN friend of mine, Laura, in Barnsley. I'm from Yorkshire, if you can't tell. And she's up in Yorkshire as well. And in their clinic, they did this great study, and it's been published, where they got their patients who were coming in the self-care journey. And they saw their patients in clinic once in 6 weeks. The rest of the time they were self-caring. Yes, they gave them the contact numbers. Yes, they gave them all the advice. If they had a problem, then they'd come back in. But those patients, and there was like 90-something, went on to a healing trajectory in sort of quick sticks type of time. So it worked for them. It's been proven. I mean, it's brave, but we can do it. We need somebody to take the mantle and go, do you know what? Let's give this a go. So what are appropriate self-care solutions? Well, it's that it can be applied by the patient, as we said, or the carer, or the healthcare professional, in intermittent stages. We're controlling the exudate, and then there's, the limb is got to a good shape. So there we go. That's a good example of, tick, tick, we can do self-care. We can use a hosiery kit with this. We can manage the exudate with a dressing in place, or a low adherent dressing, and we can put that the hosiery kit over the top. So we've got the pathway there. So it's guiding us through all that. It's telling us those steps, and can we use this or not? Is there an edema present or no edema? Because then that depends on the type of that hosiery kit using, because we've got British standard, European standard, so there's slightly different levels of compression within that, but and it's about the material in hosiery. There's different types of knit in the garments, and the European will control the edema better than the British class. When I was a district nurse years ago, I thought there was only British class edema, class 1 edema, and that was it. So where are we going wrong all these years? No wonder we've got X amount of venous leg ulcers. If you want to know more about the differences with those, please visit the L&R stand at lunchtime, and they'll be able to explain all that for you. So the hosiery kits, first line management. And in my clinic in North Lincolnshire, we said, right girls, this is what we're going to do. We're going to use this as first line, got our pathway, we're going to put it on there. And they were like, the patients won't go for that. I can tell you 98%, maybe 95% are in. They go in it straight away. Obviously some can't, as we've seen with the pictures. We need to bandage first, and patients love it. So that's what we did. It's so easy to put on because you've got that silky liner, which is 10 milligrams of mercury. That goes on first. And then we've got that second layer to add over the top. We've got that 40. So the different types that we've got there. So we've got the hosiery kits, and and there's an evidence trial to this. This is the Venous 4 trial I was talking about. So they did it 4-layer bandage, and we did 2-layer hosiery kits, and the healing rates were kind of the same, but the cost saving was great, and then that recurrence of leg ulcers was much lower when people were using the hosiery kits, because, as we said, they're more likely to go on into lifelong maintenance hosiery if that's what they require. So we've got the wrap systems, and that delivers that full therapeutic, like the short stretch bandaging, so really good for edema management. They're easy to put on, you can adjust them, you know, and it empowers people. Some people might need a foot piece, some people may not. But again, work with your specialists and also with our industry partners, you know, on what are the best options and for your patients if you're not sure and unsure. All these things, obviously, we have to measure them like we'd measure a piece of clothing, because we want to get the right fit for somebody, because if the fit's not right, they're not going to wear it, are they? So, but the measurements forms and things like that are really easy to use. I know at L&R they have the app. I've forgotten the name of it. You'll have to. They'll tell you on the stand. It's gone out of my memory. They've got this. I've got it on my phone. Actually, the app with all the information there and stuff. It's brilliant. It's so easy to use, and we never forget our phone, do we? We've always got our phone in our pocket wherever we are, so it's easy to get out. And then we've got the wraps. So you know they're so the advantages, the benefits are, you know, they're kind of a low profile, aesthetically pleasing. We've got different colours, because, you know, some people prefer black colours in hosiery, or you've got the beige colours, and they're so cost effective, consistent compression levels, and can be applied to a full leg. Because sometimes you're like, well, I need to go above the leg, but trying to get a bandage up here is hard, isn't it? And you're trying to put it on, and it's hard for the patient to have to manage with that, you know. Also, it's hard for us to apply it too. So you can even mix and match using some bandage and then come up above using the wraps as well. So, you know, it's a win-win. So for our maintenance and prevention, our long-term self-management should include wearing compression. And we need to make sure that people are getting their garments replaced 2 or 3 times a year. You know, we've got Daylong here today. They do a system of prescription delivery. You speak to them about that, so the patient gets it direct to their home, and they're not going to miss those updates and re-prescribing. We need to make sure that people are checking. Let's give them that information. How do you look after your skin? Give them a skincare pathway to go in. And, you know, get them to check for any dryness, swelling, like breaks, you know, that way you could get fungal infections around their toes and feet, or, you know, breaks to the leg, and then to report that. Eat a balanced diet, because we know that helps everything, and it really improves our wound healing. We need to keep our skin hydrated, so that the moisturising, and there are, you know, we have to put emollients on in the correct way. You know, downward sweep. We don't want the hair follicles getting blocked up and infected. Avoid standing or sitting still for long periods. You know, do have some exercise. And also for those who are more immobile, you know, just even if somebody has to do the exercise for them with their legs and things, profile beds will help with the venous system, or just that foot tapping. And for those of us who, you know, and then those of your patients, because not all patients with a leg ulcer are going to be 65 plus, are they? And 65 is young these days, isn't it? But, excuse me, I've been talking too much. But but then people are going out to work, and, you know, they still may have this issue. So, you know, get them to take breaks during the day. When they are resting, elevate the legs up at hip height if they can do that. You know, on some pillars, nice and comfortable. Encourage to go to bed at night, because a lot of people sleep in chairs, don't they? Yeah. And you know, because it all helps, obviously, with a good circulation and blood supply. So we've got our emphasis on early diagnosis. We want to support the optimum use of the compression we've got available to us. We've got so many options now. Embed this evidence into our practice and use the self-care solutions as our first line. Try it out. Even if we do it with one patient, what a difference that will make. and because it encourages that, the prevention of recurrence. And it's in line with, I think, all guidance that we're all singing from that same hymn sheet. There are some great campaigns out there for us to get information and advice from. Legs Matter, you might have heard of. And if you haven't, just go on the website. There's stuff for patients, there's stuff for us. And they tend to do like a Legs Matter week during the year. Often it's in June. And also we now have Squeeze in Life. And some of you might recognise this gentleman down on the end. There he is. Mr. Johnny Vegas, yeah. And so he's really supporting Eleanor with this. It's called Club Squeezing. And Johnny's, there is a video actually, if you watch it, of him. He's talking about his dad. His dad had leg ulcers, and now it affected not just his dad, but him, his mum, as a family, and the impact of that. And as I was saying, before about, you don't often get people in celebrity life talking about wounds and things. He's doing it. So that's brilliant, because then people will sit up and take notice. So we can go on to the Squeeze in Life and sign up to that. So thank you very much.